So good morning, everybody. My name is Jens Chapman. I welcome you to the August Orthopedic Grand Rounds. Today's topic pertains to one of the cardinal problems and challenges of orthopedics. That is the replacement of deficient cartilage. We have an outstanding group of 3 speakers, headed by Dr. David Patterson. We're going to explore the options of possibly replacing cartilage, which has been really particularly challenging and elusive to us, in the most high-stress joint in our body, and that is the ankle joint. Something that's about the half of the size of a business card is subjected to major stresses and strains, and is obviously subject to wear and tear. So I asked Dr. David Patterson to come up here. He's a graduate of USC, and he's going to lead us through a program. He'll be followed by Dr. Chappie Conrad, who wears 3 hats. He's the chief of Children's Hospital. He's a vice chair in our program. He's the director of our orthopedic oncology service. And he's also the medical director for the Northwest Tissue Center. In that capacity, he's done a lot of research on cartilage cell survival. And the presentations will culminate with Dr. Michael Brage, an associate professor at the Sigvard T. Hansen Foot and Ankle Institute, who has done some pretty groundbreaking work at trying to replace deficient ankle cartilage. And we're very curious to hear his lecture. So David, please guide us through this program.
Thank you. So the title of our talk is Osteochondral Allograft for Ankle Arthritis. Is this a feasible option? First, I'd like to identify that this is not a 20th or 21st century problem. William Hunter, a famous Scottish anatomist in the 18th century, and I'll draw your attention to the very last part of his statement, is that when articular cartilage is destroyed, it is never recovered. So this has been identified as a problem throughout the centuries, the problems of trying to regenerate worn cartilage. Specifically, we're going to talk about ankle arthritis, and that would be, if we break it down into both primary and secondary arthritis. Primary is typical wear and tear where there's not an identifiable cause. Secondary is when somebody can point to a specific reason why you have this degenerative joint disease. At the University of Iowa, in 2005, they published a study, consecutive patients that presented to their clinic with a diagnosis of ankle arthritis. And what you can note is that unlike hip or knee arthritis, the overwhelming majority were post-traumatic, over 70%. Also, this was over about a 20-year period, and you can see the total number was 639. So this is not a very frequent problem, not on the order of hip or knee arthritis, but is a completely different subset of population. The other thing I'd like to draw your attention to is the average age, which is also typically younger than your patient with primary degenerative joint disease. And that presents its own problems dealing with younger patients that are looking for solutions to major anatomic problems. So post-traumatic arthritis, because that was the most significant cause, they went ahead and broke that down into different sorts of trauma. And you'll notice the most common one was actually a simple rotational ankle fracture at over 1/3 of their total cases. However, soft tissue injuries, either single episodes of a sprain with persistent pain or chronic instability from recurrent sprains, were responsible for another 30%. So some of the most simple injuries in the long run were contributing to this major problem. And I'd like to introduce 2 cases that are both challenging and we'll just have in the back of our mind. These are 2 cases that current treatment algorithms do not reliably have a good answer for. The first is a 23-year-old female with global ankle pain, as well as this lesion of the central body of the talus. You can see it well here on the AP. When we have an MRI view, we can see irregularities of the cartilage surface on the talus, as well as significant bony edema underneath it. The second case is a more global case, and this is an 18-year-old female that sustained a talus fracture dislocation as part of a motor vehicle accident. She was initially treated with open reduction and internal fixation of her fracture. With subsequent hardware removal, she was unable to bear weight for over 8 months because of pain from her injury. And 2 years after her injury and treatment, she still has significant and severe persistent pain with any sort of activity. On the AP view, we see collapse of the talus, and an MRI view shows significant widespread avascular necrosis of the talar body. So what makes these cases challenging? First is anatomy. When we talk about the cartilage surface of the talus, we know that it's only about 2 millimeters in depth. And that's compared to the trochlea of the knee, which can exceed 5 millimeters of depth of cartilage. Ankle biomechanics. Dr. Alan Tenser here at the University of Washington demonstrated that as these lesions get significantly bigger, it has effects on the overall contact pressures throughout the ankle joint and can accelerate any sort of other damage. Cartilage itself, as Dr. Hunter noted in the 18th century, does not have an inherent regenerative capacity. And the age at presentation. These are patients that are frequently younger and do not have a good option for arthroplasty or arthrodesis, which are two of our mainstays of treatment. A quick mention of the anatomy of the talus. Over 60% of the surface of the talus is covered with articular cartilage. There are a few sites for blood supply entry, and this makes any sort of inherent repair attempts extra challenging because you're depending on a tenuous blood supply to repair something that already has a poor regenerative capacity. The mechanics of the ankle joint. This is a weight-bearing joint and can be thought of as a simple hinge joint. Compared to, as Dr. Chapman mentioned, as compared to every other joint in the body in the 1940s, there was a study that showed that there was more contact stress per surface area in the ankle joint than anywhere else in the body. And in the 1980s, there was another biomechanics study that showed that up to and exceeding 13 times your body weight is transmitted through the ankle joint when running. There's a disparity of the mechanical properties between the tibial plafond and the talus. The cartilage of the tibial plafond is over 30% stiffer than that of the talus. And there is a significant dependency on feedback and proprioception from the ankle ligaments. And while it is constrained within the ankle mortise, any sort of instability of the ankle, and there are several ligaments that maintain that stability, lead to an alteration of the wear properties of the ankle. And you can see here, this is a severe example, but you can imagine that that ankle joint is not going to be distributing its force symmetrically. There's a spectrum of lesions of the talus, from small focal chondral defects to end-stage arthritis. Small focal chondral defects can be addressed arthroscopically with treatments such as simple debridement or microfracture. Stable osteochondral lesions of the talus are often treated with retrograde drilling. Unstable osteochondral lesions of the talus can be treated with open reduction and internal fixation, or attempts at repair or replacement, such as microfracture, which is seen here arthroscopically, osteochondral allograft, which we'll be speaking about more, and autologous chondrocyte implantation, which is the harvest of the patient's own chondrocytes at a single surgery, expansion in tissue culture, and then reimplantation under a periosteal patch. Treatments for focal arthritis are similar and can include autologous chondrocyte implantation, osteochondral allografts, or microfracture. And for global arthritis, two of the mainstays of treatment, of surgical treatment, would be ankle arthroplasty and ankle arthrodesis or fusion. So here's a broad overlook at cartilage biology. This is just skimming the very top of it. It has an inherently poor regenerative capacity for a couple of reasons. First of which it is avascular. Second is that these chondrocytes are trapped in lacunae and do not have the ability to migrate to areas of injury. When we talk about articular cartilage, we talk about hyaline cartilage, which is primarily type 2 collagen. Any sort of attempts by the body to repair it often end up as fibrocartilage, which is type 2 cartilage mixed with type 1 cartilage. And so you end up with a surface that does not have even close to the near frictionless motion that articular cartilage on articular cartilage provides. Because of this limited vascular supply, or near avascular supply, it's thought that these chondrocytes have very limited immunogenicity, and that'll have implications for articular transplant. We also have to discuss the structure of cartilage because this is does have its own special orientation. First, we have the superficial zone, which has horizontally aligned collagen fibers. These are some of the thinnest fibers, but tightly wound with some of the least amount of extracellular matrix. And this helps both in compressive as well as tensile strength. This is thought of as the skin of the cartilage. The middle zone, right here and seen here, has some of the highest concentrations of proteoglycans. And the middle and deeper zone, the collagen fibers become much larger diameter as well as perpendicular to the surface of the cartilage. And this is thought to be resistant to shear. Also, important to the structure is the subchondral bone, which is highly innervated and highly vascular. So when we talk about cartilage transplant, we're talking about osteochondral transplant today. And that involves the subchondral bone and this special orientation of cartilage, all the way from the deep zone to the superficial zone. And anytime you're talking about transplantation of material, you always have to wonder about the viability of these materials. So specifically, some of Dr. Bugby's former colleagues at the University of California at San Diego have reviewed the viability of chondrocytes in these grafts, both at the time of implantation as well as at 6 months after implantation into a patient. And they found that the method in which they were stored, fresh versus frozen, had a significant effect on the viability of these grafts. And I'll draw your attention. These are different stainings in confocal microscopy for chondrocyte viability. This is the fresh, and this is the frozen. You can see that the viability of these chondrocytes in the frozen allografts is very poor. And that is reflected at the cell content at 6 months. In fact, there was a recent case report in JBJS from the University of Toronto where a patient received a lateral femoral condyle massive bulk osteochondral allograft at a young age. And then 25 years later went on to develop medial compartment degenerative joint disease. When that patient was treated with a total knee arthroplasty, they looked at the retrieval of that sample and found that there were still a large number of chondrocytes that were viable. Now that was an allograft that was implanted 12 hours after retrieval from the donor, which is not something that's possible today. Anytime we talk about transplant, there's always a concern for cross-reaction with the host. And there is literature on this, but it's not very broad. Dr. Brage and Dr. Meehan published a paper in 2005 that demonstrated that 6 out of 7 patients that had received osteochondral allografts actually demonstrated anti-HLA antibodies. And the 7th was on an immunosuppressive therapy. Also of interest was that 7th patient that was on immunosuppressive therapy had the best clinical and radiographic outcome at that time. And so the question is even if we say that these are of limited, these do not engender a significant immune response, that there still may be some cross-reactivity. Dr. Bugby and the group of San Diego reviewed their failures of osteochondral allografts of the knee, and we're not convinced that any of these failures were from immune reaction. And a recent review found that as increased cell viability was demonstrated with fresh allografts, that there was decreased immunogenicity for some of these frozen allografts, leading them to think that there is some correlation between chondrocyte viability and the presence of chondrocytes to the immune reaction. So with that, I'd like to introduce Dr. Conrad to also speak about osteochondral grafts.
Thanks very much, Dave. I'm going to talk about allografts and their application in the talus and the ankle. The talus is the most common example of that. And would like to discuss my disclaimers. Tomorrow is my 25th anniversary of joining the department, and when I came to Seattle, I asked Rick Mattson for 2 things. One was a bone bank, because I was into limb salvage as my oncology background, and the other was travel expenses to get here because I was broke. I'd done 2 fellowships. I want you guys to know when I did 2 fellowships, you were paid $25,000 a year. and not these exorbitant salaries that you guys are making now. So I was broke and desperately in need of a bone bank, and found that through the Puget Sound Blood Center and relationship with the Department of Orthopedics 25 years ago. I'm going to talk very, very briefly about some generalities with regards to arthroplasty in the talus, and let Dr. Brage be what he is, which is the true expert on that. And about historical issues about allografts, because there is an interesting history. So this is the rest of your life for the residents in the group, residents and the fellows. You will be making decisions now for the rest of your life about your patients between the competition between implants and biologic grafts, which will allow you the opportunity to replace small segments and large segments. So it's a very, very interesting topic. It has huge rewards for your patients and for yourself. Arthroplasty of the talus, if you just focus on that a little bit, isn't the most common indication in the lower extremity. In fact, it takes a second seat, maybe the unjustified Rodney Dangerfield of the lower extremity compared to the knee and the hip. Most of the indications are traumatic. In the old days, in these historical studies, the vast majority of indications were infectious. So you can see the dramatic change in history over the centuries. It's a more important topic for several reasons. One is because a lot of these patients are young, and because they're going to live a much longer life, the consequences are greater. And the ability to have dramatic results with these fresh allografts is very impressive. I started my career with frozen, quote-unquote, cryopreserved grafts. The cartilage was very unviable. Those joints did not do well. It took us a decade and a half to realize that. That was the decade of the 80s into the middle 90s. And when people and physicians, clinicians doing transplants realized that those joint surfaces were not adequate from a frozen osteochondral graft, that's when things began to get better for our patients and for our own results with fresh refrigerated grafts. There's a dramatic difference in cartilage between frozen grafts and fresh grafts, and that's probably the most significant comment I can make for you. The clinical results now are limited. Only in the last few years, these top two articles are from recent. Some of the articles from Dr. Brage deal with grafts of the ankle. I'm not a big advocate of bipolar, putting a graft on both sides of the joint, because we've had poor results in the past. But I would say that in the ankle, where you have constraint of the ankle and don't have to depend on ligamentous constraints and deal with ligamentous laxity like you would in the knee, that a bipolar graft on both sides of the joint might be the best indication for a total ankle transplant using biologic tissue. And that's because you don't have to depend on a lot of ligamentous constraints, but you have the constraints built into the joint itself. Now on to the history of allografts. The most popularly quoted one is a garrulous surgeon named Erich Lexer, who was trained in Berlin just as Dr. Chapman started his career in Berlin. Ended up in Munich, Freiburg and Munich. Was an interesting character that transplanted many joints, starting with the knee joint from recent deaths. He was a big believer in warm graft transplants versus cold graft transplants, and the viability of those grafts was greater than the cold grafts, and he had great success with that. He was preceded, however, by an interesting surgeon from Edinburgh named Sir James McEwen, who did thousands of grafts, starting mostly with intercalary allografts. And today, intercalary allografts are still a good indication for limb salvage, particularly for young people with Ewing sarcoma and grafts that can be intercalary and non-articular. Until we start transplanting large, fresh grafts that are osteochondral in nature, I don't think we'll be able to emulate good results at the level of the surface of the knee joint or any joint without using refrigerated, unfrozen grafts. So we've got our work cut out with us in that regard. When I came here in the 80s, total hips were the essence of orthopedics. They still are the gold standard for clinical results when it comes to arthroplasty. It's hard to improve upon 95% clinical results. We did in the early 80s have many failed joints, total hip joints, because of cemented implants and large bony defects. And those defects involved defects in the acetabulum that resulted from total hip arthroplasty. Lots of femoral heads were generated from total hips, and those were used as allografts for the next patient that needed bone stock for the acetabulum. And the easiest way to store those femoral heads was to put them in a refrigerator or a freezer in the OR. And so the bone banks of the hospitals in the early 80s were a dormitory-like refrigerator with a bunch of femoral heads in it. Some of them had been tested for hepatitis, and some of them had not. And that was the situation we walked into in the early 80s in Seattle and across North America for bone banking. It had become popular after the war. The Navy Tissue Bank had started bone banking as a popular option for patients, beginning in Bethesda, Maryland. And bone bank femoral heads were all over the United States, and poorly, and the quality was not good. We started the bone bank here through a collaborative effort with the Puget Sound Blood Center, and that's thrived as a regional facility. Allograft tissues were extremely popular. The most popular by far was the ACL graft, which was a patella graft, and was used for applications in young athletes. And they sold like hotcakes. Could not have enough allograft patella tendon grafts for ACL reconstructions. They were other popular grafts were grafts around the hip joint. Heart valves were very popular. Skin for burn centers were very popular. And if you were a young athlete in the 80s, you got an allograft for your ACL reconstruction in the vast majority of cases. Limb salvage began at about the same time in the early 80s and used osteochondral grafts that were frozen. And as I said before, those had mixed results, and it took us more than a decade to realize that a frozen osteochondral graft really didn't have a joint surface that was going to last and serve the patient. And that's when many of those osteochondral reconstructions then looked towards implant reconstructions instead of allograft reconstructions for joint surfaces, particularly in the distal femur. Intercalary grafts still exist and are a good indication today for limb salvage. Immunology for the bone, for the transplanted bone, had a much greater response with antibodies. We've done a lot of work at the Tissue Center looking at HLA antibodies to large tumor-like reconstructions around knees, which are now being emulated by the foot and ankle surgeons. And the response to bone, because of the blood supply, is much greater than it is to the cartilage. This is a mixed slide that begins to look at the viability of chondrocytes. Nothing is more difficult to assess than the viability of a chondrocyte in a graft or even in the natural setting. It's a very difficult cell to assess viability in. Surgical technique in the talus, I'll just say a couple of things that you're depending on some challenges with surgical exposure. The central posterior third of the talus is a difficult area to get to. Laterally, immediately, you have to do osteotomies to get to the adequate exposure for a lot of these graft options. The thickness of the graft is critical. The superficial layer of cartilage is really sensitive, very sensitive to desiccation. It's very important when you do these transplants that you make sure these grafts are fully hydrated throughout the procedure. The instrumentation sets for these grafts are limited. Getting informed consent for the patient is critical, and making sure you have a graft of adequate quality is critical. These grafts vary depending on who the vendor is in expense, from $5,000 to $15,000 or $20,000. Those prices are a little bit exorbitant and dependent on the vendor and what their nature is in terms of a tissue bank. The quality of the graft is also an important issue. It's very important to know who your vendor is for these grafts and how long they've been processed and what the storage time is. These grafts are procured from, in the appropriate setting, from a carefully screened donor who's been carefully screened for risk factors. This is a regulated business, but it's a voluntary regulated business by the American Association of Tissue Banks, and it's important that your tissue provider be an AATB sanctioned organization. In the early 80s, we had a major crisis with HIV all over the world. and many episodes of HIV transmission in osteochondral transplants in the early 80s. Those are the days where we're still arguing about whether a kidney transplant could transmit HIV or hepatitis. And we've come a long way since those days with screening and testing of these donors. In fact, when testing changed in the early 90s, we did a look-back study on hepatitis C with a superior test and found 2 donors that had been hepatitis C positive on the new test that were negative on the first test, and found that hepatitis C had been transmitted in 2 donors, and that many people that had received tissue didn't even know that they'd received a human allograft tissue. And so informed consent was an issue in the 80s and needs to be focused on today when you're doing these procedures in your patients. You do push the limits on screening and testing when you're trying to get a fresh graft out at 14 days. We did a study that was exhibited at the Academy in 2010 that showed that that was a safe practice, and we began to improve our ability to provide grafts at 2 weeks instead of 6 weeks. When the viability of those grafts deteriorates is a great topic for future evaluation, and the San Diego group has, I think, by far the best paper on that from 2003 or 4 that said that that viability in chondrocytes as assessed by a confocal microscopy begins to deteriorate at the 3 to 4 week mark, and that 70% viability of those chondrocytes is present in 4-week specimens when 90% viability is present in the first 2 weeks. We don't know what the significance of that is clinically. Maybe 70% viability is adequate for a transplant, maybe it is not, but we now distribute grafts up to 6 weeks, thinking that the viability of those grafts is good for the patients. The more important thing to how long that implant has been sitting in the bone bank waiting to get distributed is not the number of weeks that it's sitting in serum or fluid waiting to get distributed, but the age of the donor of that graft. I have a very simple rule that the age of my patient needs to be in the same ballpark as the age of the donor graft, and that's a very difficult requirement and criteria to satisfy with limited supply. So always ask about the donor age of the graft that you're getting ready to put in your adolescent patients. So the future choices will be great for you with regards to biologic grafts. Be aware of some of the scientific issues regarding those and be aware of what the source of those grafts are. Here's a child that I did 1 year ago that I just happened to get a fresh scapula for. He had a glenoid Ewing sarcoma, replaced his entire glenoid, and that was several years ago. He has a dramatic result. Some of my most dramatic results with allografts are from fresh grafts. Great Expectations is because of the possibilities that you can have on your patients and with your practice with the use of these grafts. Make very sure that you're educating your patients and that they know they're receiving a biologic specimen that has some comparisons to transfusions and the risk of disease transmission. Thank you very much.
Hi, thanks. So right now, for my indications for an ankle allograft do include global ankle arthritis, and that would be either post-traumatic or idiopathic. I do try to limit this to the younger person, and by that I mean under age 50, because I think prosthetic ankle replacements nowadays, the outcomes are quite acceptable. And the success of a global or a bipolar shell allograft is not as reliable as a prosthetic replacement is today. You can also use allografts for medial or lateral talar defects, and this is usually up to 10 millimeters or more, and they can involve the entire half of the talar dome or even larger, or even the entire talar dome. You can use them to salvage other procedures, such as perhaps a failed prosthetic ankle. I've only done it once. And I've also taken an ankle fusion down and replaced it with an allograft. And then certainly for osteochondral lesions, if a debridement and microfracture fails, you can use allograft. Certainly if a mosaicplasty or OATS procedure fails, and this is one example of a failed OATS. This is a talus that I took out that had an extensive OATS replacement that was still quite painful. And lastly, patients with large osteochondral lesions that don't want to accept the donor site mobility of the knee are good candidates for allograft. Now, these patients should have a persistently painful ankle, which limits the activities of daily living, and they have failed, of course, non-operative treatments, including anti-inflammatories, injections, bracings, and/or previous surgeries. The contraindications for allografts for me include a varus or valgus deformity greater than 20 degrees, a missing malleolus as shown here, significant peripheral vascular disease, of course, and other medical or premorbid medical conditions that might harm them. Non-compliance is an issue. I have a case of that. Advanced neuropathy is probably not a good idea to operate on. Extensive avascular necrosis is probably a contraindication, and then active infection. So the ideal candidate in my mind is someone who's smaller or average size, but there's no data to support this, and we certainly want them to weigh less than 250 pounds. They should have no expectations to return to impact sports or manual labor. We certainly don't want them running on these things. And that the only other option for these patients is ankle arthrodesis. Preoperatively, you have to evaluate the lower extremity for deformities, in this case a previous tibial shaft fracture, and if there's any angulation of the tibial plafond in any direction in relation to the long axis of the tibia greater than 10 degrees, that may require an osteotomy before allografting. A subtle pes cavus or pes planovalgus deformity can be left alone, but a significant deformity of the foot should be corrected prior to allografting so that you don't load the graft eccentrically. And then coexisting arthritis in the foot and ankle can be evaluated with selective lidocaine injections to help localize the source of pain. And then you can fuse these joints either before, during, or after ankle allografting. An equinus contracture should be looked at as well. And in my own hands, if I can't bring the ankle to neutral position after active assisted dorsiflexion, then I have to consider an Achilles contracture or posterior capsular contracture or gastrocnemius contracture. And then you can do a gastrocnemius recession or percutaneous Achilles tenotomy often during the ankle allografting procedure. And then don't forget about lateral ankle ligament instability. It's very important that the ankle be stable for an allograft, and you test that with the anterior drawer or Taylor tilt tests, and then you can reconstruct the ligaments before or during allografting. I simply get an x-ray with a marker, and I radiographically measure the width of the talus about 5 millimeters below the articular surface, and then I send that measurement into the tissue bank as the size of the graft that I need. I just did want to mention this again because Dr. Patterson did mention this, that we're dealing with fresh tissue and not frozen, because fresh tissue has more viable cells and that frozen tissue has actually no viable cells. Now, surgical approaches, Dr. Conrad mentioned these, and I can't go through all of them because of time constraints, but for medial lesions, you can use a medial malleolar osteotomy, and for lateral lesions, you can do a lateral malleolar osteotomy. And then you can use a Tillot osteotomy as well for the more anterior lateral lesions. And I have one case of a posterior malleolar osteotomy that I've done. And then for the vast majority of them, I go anteriorly. I distract the joint with an external fixator. So I'll just show you what that anterior approach looks like. Basically, the patient is supine on the table with a bolster under the hip. There's a thigh tourniquet, and we can cover the toes with plastic adhesive. And then I do put an external fixator on the ankle to distract the joint during the procedure. And this is what it looks like. So there's 2 pins in the tibia, one in the talar neck and one in the calcaneus, and then there is a distraction mechanism on the fixator to use. So this is the anterior approach to the ankle. We develop the interval between the tibialis anterior and the EHL tendon. We retract the deep neurovascular bundle laterally, and you do a full subperiosteal dissection to expose the medial malleolus, the lateral tibial plafond, and most of the talar neck and head. And then you distract the joint with the fixator, and you hopefully, and most of the time it does distract symmetrically like this. I use the agility ankle cutting jigs basically because that was what was available at the time. And we use a Tuke saw, and we try to make an 8 millimeter cut off the plafond, and an 8 millimeter cut off the dome, and we get about a 20 millimeter space. And you don't have to make all the cuts in the cutting jig because we're doing an allograft. So this is the cutting jig in place. We use fluoroscopy to line it up so that we're taking symmetrical bony resections on each side of the joint. And then you end up with a deficit that looks pretty much like that, which can be kind of scary. Most of the time the bone comes out piecemeal. It's extremely rare for it to come out intact like that. I think it's only happened to me once, and so I took the opportunity to take a picture of it. And you can sort of see how painful it does look painful. Now the graft preparation, I put a one-size large cutting block on the graft, and that's so that we can press fit it and allow for graft settling. And then we also try to get an 8 to 9 millimeter cut using a tooth saw. And here is the graft tissue that you can get, and it looks healthy and white and alive. And you have to painstakingly put this jig on by hand using fluoroscopic guidance, and my hands kind of glow in the dark by now. And then the talus is cut more or less freehand. You basically make the cut at the junction of the anterior neck and cartilage, and you cut straight back, making sure that you make a nice level cut. So I take all the soft tissue off the graft because I think that's antigenic. I also pulse lavage the marrow contents because I'm trying to get rid of the antigenicity. I seat the grafts together to make sure the cuts are straight. I do use fixation. I use 3.0 cannulated screws, 2 in the tibia, 2 in the talus. I check for an equinus contracture. So here is what you want to see. You want to see a nice parallel cut on each side, so that it's parallel on both the AP and lateral views. And then you put it into the body. On one side there's no screws, and then there is, the screws have been placed. And then this is what you hope to get. So you basically then range the joint, and the joint will actually seat itself. It'll find its own position. We call that the sweet spot. And once you have that sweet spot, then you can place your screws in. So post-op, it typically does look like this. You have a graft in place with screws, and now the joint space has been restored. And then you can also, I just wanted to just show a quick couple of cases using the anterior approach for a talar resection. Here is a avascular talus, especially on the medial side. And then you can see the specimen has been taken out. It's actually broken, and it's sunken down. And you can see the cartilage is delaminating off the bone. We use the resected specimen as a template. We just lay it on top of the graft and use marking pens, as you can see, and then we make our cut into the talus. I would caution you that if you do this procedure, cut it big because you can file it down, but if you've cut it too small, there's really no way of salvaging that. And then you place it into the body. You can see that we got an exceptionally nice interface between the graft and the native talus, and I do put in some screws to hold it in place. So here is a 6-month x-ray of a person that had that procedure, and you can see that the graft is healing well, and there's been a nice restoration of joint congruity. And then you can also use this for whole talar domes. This is a man who's had a avascular talus from a fracture, and this is the 12-month x-rays after a total talar dome allograft has been placed. I keep these patients non-weight bearing for 3 months, but I start early motion as soon as it is healed. And I did want to show a few cases to show you that this procedure does in fact can work, and when it does work, it works very well. This is a person with ankle arthritis, as you can see. It's in varus. This is the 3-month x-rays. This is the 2-year x-rays. This is the 3-year x-rays. This is the 8-year x-rays. You can see how the graft is slowly incorporating over time. The joint space has been maintained. This is the range of motion at 8 years. And then this is the clinical x-rays. This is the case that we just showed. This is the hemitalis, and this is a case now she's at 3 years and she has completely incorporated the allograft bone and the joint space has been maintained. It is interesting though that they do get recurrent osteophytes in the front of the ankle, but her pain has been improved dramatically. She's fully functional and she has good motion. So why do these fail? In my hands, they're mechanical and then they're probably biologic. So in my early experience, if a graft came in a little bit small, I would put it in, but I've learned quite quickly that that is something that you shouldn't do. A small graft fails quickly and it makes sense. I mean, it's too small. So this is a graft that failed quickly from it being too small, and if you do this procedure, either accept the exact same size that you need or even slightly bigger, but do not put in a small graft. I also thought in my series that if I cut the bone too thin, that led to early collapse and failure. So we do try to make a little bit of thicker cut now, 8 to 9 millimeters. Again, too thin of a graft would fracture, but too thick may result in a higher antigenic load. Now, if it's a heavy person, I think this is also a contraindication. This is a lady that just crushed her graft. She also has a little bit of a flat foot, but she was a very obese woman who was a person who showed her dogs in professional events. And you know how they have to trot with the dogs? She needed to trot with her dog, and she did that and crushed her graft. Catastrophic failure happens. Also, I've only had one case, and I do think the graft was slightly cut wrong. The problem with this procedure is that you can't cut the graft wrong. If you cut the graft wrong, it's kind of doomed. So if you cut the graft wrong, you will get a failure. And I've also been asked, am I creating a neuropathic joint by cutting out the both sides of the joint? And I thought about that for a while, and since I've only had one real catastrophic failure, I don't think that we are creating a neuropathic joint, but it sort of makes sense that if you cut the joint out, you might be devascularizing and denervating the joint. Patient compliance is an issue. This is a person who walked 15 miles on the first day. I said they could walk some, and he fractured his graft up through the middle like that, so that's a real issue. And then more mechanical failures include residual deformity. This is a lady that had a little bit of recurvatum in her tibia that I did not correct. And you can see that the ankle is not under the weight-bearing axis of the limb, but this graft did last 5 years and was doing well until she sprained her ankle off the curb, but then she became arthritic. This is Mark Meyerson's paper, published in 2008, and his results also corroborate mine. He had successful patients in lower body mass index people and with minimal preoperative angular deformity. I don't know if the older patients in my experience were more successful than younger. Now there's probably biologic failures as well. There's non-unions, and there's always a few of those, and I don't care what procedure you do, there's always non-unions. This is a man, 39-year-old non-smoker, and he had a non-union of his partial talus there. He didn't want a fusion, he didn't want to wait for a new graft, and I offered him a repair of his current graft. So I was able to take this current graft out. So this was in the body for 2 years, and you can see that it looks okay. There's a nice thick cartilage shelf on it still. Maybe the bone has revascularized some, so it wasn't like the graft itself died. I did put it back in. I fenestrated the area, burred it, put in local graft. I put in bone morphogenic protein, and post-operatively, you know, it looked quite good. The graft was back up to its original position, but it still did not heal. And this patient now we've recommended an ankle fusion, and he's thinking about it. This is the most common failure I've seen, is a slow progressive loss of cartilage over time. So here's a man that's 1 year post-operative, and then at 2 years it's narrower still, and then at 3 years it has gone down to a bone-on-bone arthritic condition again, despite the fact that the bone has that has healed, and even the allograft bone is being replaced by native bone. So the cartilage did not survive the transplantation, and we already discussed, both Dr. Patterson and Dr. Conrad talked about immunologic response. There are papers that look at cartilage-specific proteins now that in graft patients, and they are being found. Marrow elements have always been shown to be antigenic, and then in our own study we showed anti-HLA cytotoxic antibodies. What this all means, no one's really figured it out yet. I'm not of the impression that cartilage is immunoprivileged. I think the body sees a foreign cartilage, and I do wonder if the body is attacking the cartilage over time. On the other hand, my other theory is that the cartilage just doesn't survive. If you put cartilage, if you replace a degenerative ankle with a bipolar graft, it might be that the milieu of the patient just doesn't support cartilage survival. That's why I think partial allografts of the talus work better. I think the synovium is healthier in these people, and that it's a more friendly environment for the graft to survive. I looked at my grafts last year, and I looked at the 2-year follow-ups. I had 62 grafts in 60 patients, and these are only bipolar grafts. But 37% had failed. So it isn't something that you can say 85, 90% success. You can say maybe 60% success. And 7 patients have undergone repeat grafting. 2 underwent prosthetic conversion. I lost 1 to follow-up. 1 had an elective below-knee amputation. 1 patient died of a massive pulmonary embolus, and 1 patient underwent ankle fusion, and the rest are considering their options. And then we're back to you.
Stay here. So these are 2 cases that we discussed earlier. First is this 23-year-old female with global ankle pain and this central body lesion, just a reminder of her MRI. And this was that one case that Dr. Brage was talking about where you would possibly consider a posterior osteotomy. In this case, the screw hole was pre-drilled before the osteotomy was performed to ensure an anatomic reduction of the tibial plafond. The approach was from a posterior lateral incision, and here is the posterior malleolus osteotomy. Here is the cartilage defect. This is preparation of the talar dome. There's one part of a osteochondral allograft and a subsequent so-called snowman configuration. This is with the osteotomy and that restored. Here's post-op follow-up at 6 months. And here's case 2, the more challenging case. This is our 18-year-old female. It sustained a right talus fracture dislocation and went on to avascular necrosis. Here are some images intraoperatively. You can see here is her native necrotic cartilage and subchondral bone, as well as the graft. And here are her immediate postoperative radiographs. It was performed through, in addition to a lateral malleolus osteotomy, a primary subtalar fusion was also performed. And here she is 15 months after her surgery. So some conclusions. This is a rare but challenging problem. There have been remarkable advancements on the viability of transplanted osteochondral grafts, but there continue to be advancements. Recently, tumor necrosis factor has been identified as a problem for these grafts, and some of the rheumatology medications that are anti-tumor necrosis factor medications have been shown to improve the viability. So we feel that bulk osteochondral allograft is possibly in the treatment armamentarium for the right patient. Thank you.
So excellent presentation. Thank you for your hard work there, David, Michael, and Chappie. So I have a question about anti-inflammatories. What do you tell patients about anti-inflammatories when they're considering undergoing such a surgery? Do you stop them, and does it have an influence on bone healing and cartilage cell survival?
So I actually, obviously I would stop that right before surgery because I do think it probably thins their blood out a little bit. And post-operatively, I have allowed them to take the anti-inflammatory if they needed something additional in terms of controlling swelling and pain. I only have had a few non-unions, and I don't attribute it to the anti-inflammatory.
I would use it because I'm concerned about subtle rejection in these larger bony grafts, and I was interested to see Michael's larger bipolar grafts. You know, the worst bone you can do an allograft in is the tibia, and I think the ankle's part of the tibia, kind of. And so if you're doing these, I've had a couple patients just never heal a tibial graft for vascularity issues, probably adding on a little bit of not liking the graft antigenically. I've tried to tissue blood type these grafts to minimize the inflammatory response to bone. And in the end, I've just put them in a Sarmiento to protect the weight-bearing part of it for 6 months for the large tibial grafts. And I wonder if you're doing these big bipolars in bigger patients, you'd probably be better off to protect. I would put them on anti-inflammatories to calm down the immune response a little bit. The cancellous grafts are going to heal most of the time if you do them in other bones. The metaphyseal part of these grafts will heal fairly predictably, and they will remodel the bone for 1 centimeter. So I like very much your 1 centimeter rule for the thickness of subchondral bone. But I would control the inflammatory response a little bit with some anti-inflammatories, and I'd protect them with a splint as an elongated response.
And then there's, even more interestingly, a paper out of Italy came out with their results of bipolar grafts, and they kept their patients non-weight bearing a little bit longer than I do. I just arbitrarily chose 3 months because we were starting this up in San Diego and just said 3 months. But they kept their people on non-weight bearing for up to 5 months, and their outcomes are better. So maybe a little bit more non-weight bearing could help.
So the intriguing thing is you put a bipolar total ankle graft in there, they'll heal that thing in 3 months without much doubt. And then they're going to beat the hell out of it. If they're 15 or 16, they're going to beat the hell out of it. And if they're bigger and heavier, they're going to beat the heck out of it. So you're really better off, you need to splint those people because that 1 centimeter, if it's anything bigger than a centimeter, it is brittle enough for them to split it, just like you were showing. So I think I admire the honesty of your results because I think that's exactly what I would have guessed. And because the expectations are so exorbitant in the practice of what we do now, and you're right in the middle of the road with that, with these big grafts, they are going to be stressing that brittle bone pretty vigorously at about the 6-month mark. And that's why I would just protect them for 6 months and then hope that the graft is thick enough and the vascularity and the reaction to the bone is good enough that you minimize your failures, even with your good results.
Dr. Brage, I was wondering if you would address case number 2, where you said earlier that widespread avascular necrosis was a contraindication, yet here's a 18-year-old that has that.
Yeah, so this case was, it is what we call a real home run. She came in on crutches, barely able to put any weight down, 18 years old, extensive avascular necrosis, and she probably should have either had a fusion or even a balloon amputation. And so this is actually the case that's ideal for this. I mean, you may as well try it. You have nothing to lose. And so we did a subtalar fusion to try to get blood flow up through the talus from the fusion. We did resurface it with an allograft. I went through the fibular side because the soft tissues in the front of the ankle were so adherent to bone that I was frightened of causing a necrosis of the tissue. So this is, this is surprising to me that she's doing well, but she did heal. You can see that the graft and everything is incorporating well. And so this is a great case because she had nothing to lose and everything to gain. And I'm just delighted that it worked out so well for her. So.
So what was her necrosis diagnosis?
Well, she had a severe trauma from a motor vehicle accident and had a talus fracture.
Right. So the number one indication for me doing small grafts is in leukemic kids who have had steroids, who have had a systemic problem for a while and then get over it. And they do well with their grafts. So a local necrotic idiopathic necrosis is not a contraindication for a graft. Would you agree with that?
Yeah, I would agree. As long as there isn't, yeah, I would agree with that.
Thank you all.